Thank you very much indeed, and thanks for asking me. So, yes, I'm John Dean, and I'm Clinical Director of Quality Improvement and Patient Safety at the Royal College of Physicians, and I'm a physician in East Lancashire. And I'm presenting this work on behalf of a wide team that has done work over the last couple of years trying to formalise guidance in terms of modern ward rounds. So what I'm going to do is run through a presentation of key elements of the modern ward rounds guidance, which is now published and available to you all. And then at the end of that, we'll enter into a discussion that might draw out some of the points more, perhaps some of the challenges of implementing this. Okay, so in 2012, the Royal College of Physicians and Royal College of Nursing produced guidance called Ward Rounds in Medicine, Principles for Best Practice. That guidance was well received. It's been very widely referenced, but I think it's fair to say that many of the elements of it have not been implemented because of lots of challenges in the system. So the group that you see written on the right here, wide group of multi-professional stakeholders representing professional organisations, also representing patients and the wider NHS, came together to review modern practice around ward rounds. As part of the evidence gathering, we developed quite a wide network of hospitals and practice teams who were doing exemplary work in ward rounds, and we used that evidence to bring together the guidance, which is an amalgamation of good practice. We also used surveys of professional members to understand what was happening, what challenges they were currently finding in terms of delivering effective multidisciplinary working, which should be focused on ward rounds. So in the centre of your screen, you will see what we describe as the effective ward round. What's important in this is the ward round doesn't stand on its own, but we are suggesting that the day will start with a good shift handover. That might be one profession, perhaps nursing. It may be multi-professional. But the information from that shift handover need to then feed into a board round where the multi-professional team come together and understand what's happening with patients on that ward that need review. Following that, there will be a whole series of information that comes together to inform decision making, and the function of the ward round is to collate information and then develop decision making with patients for further action and management. So a key element of this model is the information gathering that feeds into ward rounds, and you'll see a whole series of those, and we'll come on to it in more detail. The ward round itself is a multi-professional approach, so key members of the multi-professional team need to understand how they work together during this. It needs to be understood who's leading it. It should start with a briefing in terms of the purpose, how the team's going to work, what the different roles are. So the key team members need to agree their roles and responsibilities. It's likely, and it should happen, that patients have been prioritised at the board round, so that then patients are seen in priority order. And the purpose of the decision making is to confirm the diagnosis, address the patient's questions, review their progress against the plan, check safety measures, teach and learn as a multi-professional team, revise that plan with the patient, and complete structured documentation and assign actions. So that's what happens in the ward round process. It should be followed by a debrief of the team around what's worked well, what hasn't worked well, any challenges that there might be, and any learning that has been. Very importantly, following that, the whole multi-professional team should come back together for an MDT handover around plans for each patient, which may be informed by other things that have happened during that time. And then there are outputs, as you can see from the ward round as well. So that's the idealised process. So I'm just going to, bear with me, try and move down a slide. Okay, so apart from that flow of process and decision making, there are other things that happen in multidisciplinary wards that will inform decision making. And what's key is that multi-professional decision making on the ward round or by the team coming together at another time is central, so that you can see a number of functions that happen on wards by different members or collectively of the multidisciplinary team. And all of that information should feed into and out of the ward round. So we see the ward round as being central to coordination and decision making of the multi-professional team. So we described some fundamentals of ward rounds, that they're well led, that they're structured, that you've got effective teams working together, that there is patient involvement, and that there is education, learning and improvement happening as a core part of them. Two key recommendations you'll see in the middle of this screen. The first is that there is not a need for the continual presence of every member of the multidisciplinary team on the whole ward round, but you must agree how the information from those professionals feeds in and out of the process for good multi-professional decision making. However, the people who know the patient best need to feed into that for their patients, and that is commonly, and probably most commonly, the nurse who's directly looking after the patient. It's also important to try and keep the membership of that multidisciplinary team as consistent as possible. And that requires some planning, because if we have a more constant team, we're more likely to make good decision making and have good communication. So what's happening in practice? Well, the surveys told us quite different things, really. So consultant physicians were saying that somewhere between 10 and 20% of the time, the nurse looking after the patient was input into the decision making on the ward round. Nurses were telling us that they participated in ward round 60% of the time. So there's a difference in concept there around what we mean by involvement in decision making, and that needs to be explored by individual teams. Nurses also stated that they wanted to be much more part of the decision making, but were often prevented to do so by other priorities. Similarly, you'll see the data around pharmacists, a dissonance there between perception of the physicians and perception of the pharmacists in terms of input. But it's clear that medicines management is a key component of multi-professional decision making, so that interaction needs to be agreed. So agreeing the roles of the multi-professional team members and their input to the ward rounds is a vital part of planning. Scheduling is also vital to effective multidisciplinary team working. And what we commonly find when ward rounds and the associated processes are not working well is because there's been a lack of scheduling. The multi-professional team don't all know at what time which things happen. They might start their shifts at a different time for different members of the team. They don't know what time the post-ward round MDT is going to happen. The timing of the ward round might not be the best time to aid patient flow from decision making, or it might take too long because we might be trying to do too much during that process. There are things that can improve the speed of ward rounds, and there's good examples of dialogue scripts that can be used that speed up information exchange and decision making. And interruptions are very common, so we need mechanisms to prevent interruptions. Common practice is that coordinators of wards join ward rounds. Coordinators of wards will be interrupted on the ward round, and therefore our recommendation is that they interact with the ward round but are not necessarily present on the whole of the ward round, but that the nurse looking after the patient is the best patient who knows the patient well to impact to the clinical decision making. It's important that other patients and the responsibility of that team are understood by that multi-professional team. So any patients in other areas that require input from that team should be considered during the whole ward round process. So breaking it down, let's think about the time that preparation before the ward round. And our surveys and experience tell us that when ward rounds aren't functioning well, it's because the preparation has been inadequate. There is dissonant guidance in terms of this. What's important is that good decision making is made by the multi-professional team so that the outcomes and the actions can happen in a timely manner, either directly after that patient or following the ward round. But if there's inadequate preparation, then the decision can't be made and is likely to be delayed till either later in the day or even the next day. And therefore, if that means that the preparation takes time before the ward round starts, we are still more likely to get more timely decisions by that information being available. So the handover of information from the night shift, what the patient's symptoms are, what the patient's questions are, what individual professional reviews have told us, how the information from investigations comes together, needs to be prepared before the ward round, not during the ward round. Otherwise it delays it, there's missing information and decisions don't get taken. So you'll see on the right here some key elements around before the ward round, again highlighting the need for the team to come together and to understand their roles and to plan. So the bottom one is important. So if there are patients with communication difficulties, plan how you're going to deal with those and manage that before you get to the patient, before the ward round. So to some people who've not been involved with ward rounds, they're a little bit of a black box. People huddle together, have conversations, look at screens of computers and sometimes come out with decisions. But actually there's a whole series of decision making that happens and that should happen. What's really important is that is that the patient is involved. They're introduced to people in the ward round, their questions are answered and prepared. And then there's a whole series of information and safety checks that inform decision making. Now, all of those don't happen on the ward round, but if you've got the right preparation, then any that need highlighting because there are abnormalities or concerns would be fed into decision making. And documentation is a key part of ward rounds. Clear, structured documentation with prompts for key areas and actions. Clear documentation of decision making, checklists for safety issues, and documenting criteria around discharge, transfer, other decisions, documenting that really clearly. And sharing what is documented in summary form with the patient and family, if that's possible. And there are examples of good practice for that. So a key theme of the Modern Ward Rounds report is that patient involvement, patient-centred. And this is what patients told us in the workshops that we had, that they see the ward round as fundamental to decision-making around their care. They need to input to that care and they need to understand the decisions and agree the decisions that come out of it. And if they see effective teams, that gives them confidence in the care. But that's not the end of it. They need to know what's going on. They need an update on how the plan's going later on in the day. So there are some key elements of communication with patients, that they know what's going to happen and when it's going to happen in terms of decision making, that they can input to that with preparation, that there's written information that explains it to them and their families, and as I say, any communication difficulties are preempted and overcome. One of the most fundamental things that patients told us was that they want the professional who's talking to them to be sitting at the same level as they are, not standing over them, not shouting from the end of the bed behind a mask, but sitting down, having a conversation. It's a very simple intervention that makes a huge difference to patients. So address the patient's concerns, ensure there's communication with relatives, and follow up with what's happening. So following the ward round, there should be a debrief. What have we learned? What's gone well? What will we do better next time? And the board round of the whole multidisciplinary team around the actions and decisions to progress that patient's care. Central documentation using whiteboards is helpful so that everybody knows the progress. And if the board rounds happened in the morning, then an afternoon huddle to catch up on progress is important. It's also doubly important that if there's not full 7-day working, that on a Friday the weekend plan is really clear around priorities of who needs what and who needs to be focused on in the weekend ward round. So all of that is great from a human point of view, but if the physical and technical environment isn't right, it's not going to happen well. So we need to make sure that when these discussions and decisions are happening, it's an undisturbed area, that there aren't other tasks happening at the same time, that there isn't cleaning of the floor, that there aren't other conversations going on. It needs to be a quiet environment for clear thinking and decision making. Equipment needs to be maintained and available, but there also need to be opportunities to go into other areas for more confidential conversations or sensitive phone calls or documentation that need to happen. One of the biggest changes in the last 8 years is the role of technology. Computers are now commonplace on ward rounds, and sometimes 3 computers on a ward round. And one of the dangers is the focus becomes the computer and not the patient. But what is equally frustrating is when that computer hasn't been charged or hasn't been kept up to date, or the software isn't working, or the people using it aren't aware of the software, or the Wi-Fi is not working for mobile devices that contact other information. So maintenance and update related to technology is a key part of preparation for ward rounds and part of ongoing housekeeping. Education and learning is fundamental to multi-professional ward rounds and multi-professional care on wards, and it should be seen as a core part of the process. But also training in performing ward round practice, how you share information, how you structure that, how you document it, how you communicate it and involve patients. And there are examples of good practice where simulated ward rounds develop professional practice. Summarise learning points at the end of the ward round, and patients need to know that education and training is part of that process. So what we include in the modern ward rounds guidance is a self-assessment template for clinical teams on wards for each of the key elements. Where are they on a scale of 1 to 4, and that helps them to highlight the areas where they need improvement or where they can share good practice. And we also have a good practice guidance around examples where all of the elements that I've talked about are happening in the NHS today, but they're not happening consistently and they're not happening necessarily collectively. So Unit 1 have done work internationally around handovers and multi-professional care, and have structured dialogue scripts that can get the interaction with each patient down to between 8 and 13 minutes. I'd really recommend you look at their work. Nottingham University do training of multi-professional staff in various ways for ward rounds and decision making. In my own trust, we've had a model ward round programme where we've tried to develop standard practice across wards, and we're particularly focused on the role of the pharmacist, so that each ward has a dedicated pharmacist taking extended roles on that ward and really contributing to decision making and actions that come out of that. South Tyneside and Sunderland have a well-formatted debrief programme that happens across multiple wards around how things are going, how well people are, how well the team is functioning. In Sweden, modernwardrounds.net actually do 80% of their ward round not at the bedside, but with the patient in another private room. And this is on a general medical ward, which includes elderly patients. Again, look at their work. It is quite illuminating. In Southend, they've really advanced criteria-led discharge and the documentation of that. In Surrey and Sussex, they've trained literally thousands of practitioners in ward round practice. And in Warrington, Holton and teaching hospitals, ward round practice is a core part of their ward accreditation scheme. And I think we're increasingly seeing that across multi-professional ward accreditation schemes. So hopefully what I've been able to share with you today is a summary of the report, some key stimulus is for you to look within your areas around self-assessing against practice, look in the guidance at good practice, look in more detail at some of the recommendations, but importantly, share that practice through your network so we can learn together how to develop this practice further.